And thank you everybody for being here today. Just your presence being here tells me that one, you are interested in dementia. Second, you have dedicated to finding what it is and provide the best care for your patients. And I also know that there is a wide range of people here with different kinds of experiences. Some of you are physicians, some of you are nurse practitioners, some of you have an interest in the field of dementia. So as I go through the next short talk, I'm going to try to keep all of you in mind when the discussion takes place. So I'm going to talk about the differential diagnosis of dementia. Just to start out with, what are we actually trying to do as a cognitive neurologist, or even as a general physician or a nurse practitioner who is seeing these people coming to your clinic? They don't tell you they have dementias. So what are they coming to you with? They're probably telling they're having forgetfulness, irritability, mixing up words. Maybe if you're in Las Vegas, you probably get a lot of people having pathological gambling. Financial mistakes, there's probably crossovers with pathological gambling, repeating conversations, losing social grace, fumbling in familiar tasks, difficulty in the normal activities of daily living, driving problems, apathy. So these are general problems that people are trying to articulate. For that, they need to have some insight, or the family member has some insight that things are not just right. And they're here in your office for you to make sense of that, to abstract from these problems and come up with a solution and make sense of it. So for making sense of the problems, you need to know what is dementia, and that's what this topic is about. What does the spread of dementia syndromes look like? The primary question you're trying to answer for each of these people is: this is a reversible cause or a non-reversible cause? I mean, basically, that's where the money is. And sometimes it's very hard to find out where do they fall in this category. I've had patients come in with the diagnosis of dementia and even specific diagnosis of dementia, like certain syndromes. And after a clinical visit, you find out that they have a very reversible reason for their cognitive problems and not a progressive neurodegenerative problem. This is a huge thing for the patient when they're given a diagnosis of dementia. So being aware of the possibilities in front of the patient is as a physician, a crucial role that you're playing. So the goals of this talk are, one, to answer what do we mean by dementia. When different people have a different sense of having what is dementia means. Sometimes your patient is going to come to you and tell you directly, I think I have dementia. So what does it mean to have a dementia? What are the implications of it? So how do we identify it? What are its common etiologies? How do we distinguish reversible etiologies from irreversible etiologies? I mean, as you see, this is primarily a clinical-oriented talk and focus, and I hope to set the platform for the rest of the speakers to follow through, so that you can kind of, put in whatever we're seeing here, or some of the names that come across get fleshed out in the subsequent talks that are to follow. So the next few slides are not on your presentation, but I think they're kind of crucial to understanding what especially this talk is going to be about. It's a map. There are different kinds of maps. There are political maps, there are geographical maps, there are maps of the ocean, there are maps of physical properties, political boundaries, financial changes, population. But the point of the map is actually to relate one part of the world to another. As a kid, you might have looked at maps and read off a country or a place, Japan maybe, or the Aleutian Islands next to Alaska, and kind of wondered what it is. Names are very evocative, but you don't know what it means. So the point of my talk, as you go ahead, is to give you a sense of the map of the world of dementia, to evoke certain names and give you hopefully a sense of how one relates to another. So when you see a patient, they don't tell you, this is what I have, but you have a sense of possibilities opening up in front of you, and hopefully you will take a map of the dementia with you when you leave. But maps are also not fixed, they change. This is a map from the Middle Ages, from the 13th century. This is also a map of the world. And you see, it's hard to find out where is Europe, where is Africa, where is Asia. If you look closely, Asia is supposed to be on top of the world, and there is Europe on your left and Africa on your right, and that was a known world. And it didn't stay that long that way. The field of dementia is also progressive, and the change of how you relate to different conditions is a dynamic process. We are, I think, at a point, at an evolving stage of what dementia means, and different etiologies and how they connect to each other. So it's a fascinating time. Maybe a century from now, most of these topics would be more fixed, like how our understanding of the world map is. It's not a dynamic anymore. But it was once upon a time, and we are, at least in this field, at this point. If you look closely at this map, you also see some interesting, figures. There are unicorns, there are birds growing on trees, there are men with strange shapes, things growing out of their noses and things like that. This was also real for people at that time and age. They were trying to make sense of the world, and they're trying to put all these things together in the best way that makes sense for them. So in the world of dementias, I'm going to walk through some of the etiologies and conceptions that may be strange, and that might change over a period of time. But it's important to keep in mind that we are in a stage of progression. As Dr. Cummings and Dr. Bernick had mentioned before, the idea of AD and what AD means also has evolved over a period of time. And how one kind of dementia and pathology fits into another also has evolved. So I hope these 3 slides set the stage of what has to follow next, and at least what the attempt is to how to relate different kind of etiologies one to another. So let's start out with the working definition of dementia. So the idea here is to define a clinical picture. So we are really focused on real-world functional capability problems. So is there a progressive decline from your previous functional status? Is it disabling? Are your activities of daily living impaired? Are there environmental problems or other alterations in brain functions like delirium or stress or psychiatric illnesses that can explain what you're seeing? So often memory is a striking complaint, but sometimes they can have other problems unrelated to memory. Is it language? Is it visuospatial problems? Is it executive function? Or even social cognition, which is getting a lot of prominence these days. So that's what we're trying to, we're trying to put together all the conditions, what dementia means. So we are not still at the etiology aspect of things yet. This is a clinical working picture. You have heard of the term mild cognitive impairment. It is a controversial term. It is a construct, as Dr. Shelton was mentioning yesterday, that is being used now. But it is distinguished from dementia, where in dementia the activities of daily living are clearly affected, and there are 2 or more cognitive domains are involved. Memory disturbance is prominent, but it's specifically related to short-term delayed recall, and executive functioning or planning also may be impaired. So in mild cognitive impairment, you might not have all these aspects. So for identifying dementia etiologies, you need to pay close attention to the clinical reports. And I'm going to come back to this slide a couple of times as we go through this talk. But this is basically the core of how do you distinguish different kinds of etiologies of dementia. You look for, are there changes in the ADLs? Well, that helps you distinguish from, early or mild cognitive impairment from dementia syndrome. Is there a clear sense of progression, and what is the age of onset of the problems? Are there clear provoking factors that you can identify? So obviously, the patient is not going to come and tell you this is my provoking factor. So a lot of questioning, a lot of history depends on your skill set and what kind of options and possibilities you have in mind as you face the blank sheet of the patient. So it's something. It is a creative act between you and the patient as you go through different aspects of the diagnosis. So also pinpointing cognitive domains. What are the things that you should be looking for? So you're not specifically focused only on memory, because now you are clued in and cued in to try and look for other changes in cognitive domains. And you also take a close look at their parallel medical histories. Maybe all the things that the patient is actually noting can be explained by other concomitant problems going on in the medical story. It is also important to ask some baseline questions. What is the patient like before all these things started? What was their baseline performance? Are you talking to somebody with a pervasive developmental disorder where they had starting out significant problems in the performance of the ideals? Or are you talking to somebody who is a high-functioning journalist and having specific problems in typing his story or her story? I mean, so suddenly information is very important. Where they were functioning is very important to make further challenges as to what the possible etiologies could be. So are there possible factors masking baseline cognitive performance level? So the other issues could include things like their mood, or in terms of their psychiatric illness or medications, some of the things we can talk about next. So the baseline performance is clearly shown to be affected among multiple epidemiological studies by age, your education. So every 4 years of education is giving you two years or so of protective period in your decline in your memory function in epidemiological studies. Physical activity level, people who are active, even in middle age, they have shown that subsequently affects their cognitive performance later on in their life. Previous medical comorbidities and risk factors, including diabetes, hypertension, hypercholesterolemia, are really crucial, because most of the dementia syndromes that you see later on in your age, as Dr. Shelton is going to talk about, is related to vascular risk factors. So these factors mediate cognitive and brain reserve. So are there possible reversible factors masking performance level? This include medical illness and medications, significant psychological stresses, depression, substance abuse, and toxicity. Some of the, I would say 2 out of 6 patients that I see don't have a neurodegenerative problem. They have reversible issues that they have concerns about changes in performance related to some of these things. But it's a tricky task to identify what specifically is causing this problem in each individual patient. And that's where your skilled response comes in. So in generally, everybody does this just to walk through what we do: a history, a course, a risk factors, mental status exam, a neuropsychiatric assessment, a neurological or medical exam, and brief lab studies that I can talk about next. And some neuroimaging kind of makes the bread and butter assessment of a dementia patient. So before getting into the different types of dementia, what does this whole picture of dementia look like? AD is the most common, but there are clearly other kinds of dementias, like dementia with Lewy body disease, vascular dementia, frontal temporal lobe dementia, hippocampal sclerosis dementia, and a mixture of all these things. But knowing this figure does not help you in front of the specific patient you're sitting. You probably can make a good guess that he or she may be having Alzheimer's disease, but also be aware that there are other options that the patient could be facing. Why do you need to distinguish different kinds of dementias? One is that the course of progression of the disease would be different for different dementias. You could say a more rapid progression in Lewy body disease versus vascular dementia, which may be significant for that specific family and the patient. And those are some of the ways that coming to you and your knowledge of different aspects of things and ability to distinguish them might be useful. So again, you have to pay attention to the same thing: progression, provoking factors, specific cognitive domains, parallel medical histories. So we can split out, while mapping the dementia syndromes, based on some cueing factors. Some kinds of dementias tend to have common features, and you'll try to walk through some common features and see When you see this specific aspect in the patient, these are the possible etiologies that you could think of. Again, I'm not going to be talking about the specific details of the dementia syndromes that will be talked about in the subsequent speakers. My job is to kind of cue your brain and make you stand up and take notice of how one dementia syndrome relates to another when the subsequent speakers come and talk to you about them. So less than 65 years of age, young onset Alzheimer's is most common, but you also can have frontotemporal dementia syndromes, Huntington's disease, prion diseases, Korsakoff's amnesia after alcohol abuse, large strokes masquerading as dementias. In other syndromes, there's a whole heap bag of syndromes that you have to get into if you cannot find a clear etiology in your previous workup, including things like Wilson's disease or mitochondrial disorders or Kuff's disease, Far's disease, and all those things that you probably heard of. But you might land a patient who has that. So being aware of these things that are possibilities is crucial. Between 65 and 80 years, again, Alzheimer's disease is the most common. But then you start having things like Lewy body dementia, multi-infarct disease, frontotemporal dementia syndromes. At this age, you also start seeing Parkinson's disease dementia, because the Parkinson's disease dementia usually starts towards the end of the progression of the syndrome of Parkinson's disease. So again, it's not very common to be seen in young onset patients. Over the age of 85, you start to think mostly mixed dementias with vascular and Alzheimer's disease as the most common diagnosis and mixture of these things. It is now clearly recognized that age plays an important role in finding out what kind of dementia syndrome the patient is facing. And that is a huge clue for you to ask other questions to follow up on that. You can also get things like cerebral amyloid angiopathy or hippocampal sclerosis dementia, Lewy body, and argyrophilic grain disease. All the things are possibilities in older patients. And as the aging population increases, these things become more important for the physician. So some of the diagnoses cannot always be made clinically. So even some of the patients who have diagnosis of Alzheimer's disease may end up having things like argyrophilic grain disease, which is a milder form of AD that shows a clinical form of AD that shows up with age, where they have changes in their with silver staining and swelling of the neurons that's being increasingly recognized at autopsies, but we still don't know how to distinguish it clearly clinically. Hippocampal sclerosis dementia, where you can have it's usually sclerosis of the specific hippocampus having memory problems that has most commonly a probable Alzheimer's disease clinical picture, but then you can have it in combination with other syndromes like FTD or Lewy body disease, which complicates the diagnosis and the progression of the disease. People with hippocampal sclerosis dementia don't have as severe a dementia progression as, say, Alzheimer's disease. You can also have myopathies like neuronal intermediate filament inclusion disease, which presents like an FTD-like syndrome. The reason of bringing these things or these names is actually, again, to show you the spread of the disease patterns that are available within the dementia syndromes. We can also look at provoking factors and parallel medical histories and look for reasons why they can have dementia, including autoimmune diseases, where you can have antithyroid antibodies, the lupus syndrome, the Sjogrens, or paraneoplastic syndromes. These are very easily missed. Many of the autoimmune diseases, patients can complain of some cognitive change, but they don't make the relationship that these things can also cause changes in the brain. Sometimes with pretty normal-looking MRI or some white matter disease, which is not investigated further. So we do get a significant amount of patients with these kind of syndromes looking for answers, or which has been blown off and not taken seriously how one relates to another. You can have infectious reasons from prion diseases or Lyme disease or Whipple disease, toxoplasmosis. In the workup of a dementia patient, after ruling out common scenarios, further workup is needed in these areas. Endocrine problems like hypothyroidism, hypoparathyroidism, and all those things have to be looked into. Vitamin deficiencies are very common, especially in the elderly patient when they're living alone and they're not cooking as much, and they're not eating fresh food. different kinds of vitamin deficiencies in combination can present and fool the patient and the clinician after elaborate tests including MRI or PET scan, which can lead you down a false track. So that's important to treat and take seriously. You can also have other etiologies like post-radiation encephalopathy, tumors, and toxicity syndromes from metals, medications. And medications are commonly abused. Most elderly patients have more than enough medications that they don't need, and which have significant anticholinergic side effects. And it is interesting to see many of the patients come in with 3 or more anticholinergic side effect medications, and in addition to that, an Aricept. It's like you're balancing out with some anticholinergics and giving Aricept, and it's not going anywhere. But sometimes physicians, giving them, do not recognize how one relates to another and what exactly is being done by different classes of medication. So that's very important. I see quite a few patients that way. Traumatic brain injury, as Dr. Burdick was mentioning, is a risk factor for progression to Alzheimer's disease. But they can have other problems that can masquerade as dementias, like subdurals and disconnection syndromes. Some of them can be recognized on MRI, some of them cannot. The long-standing subdurals are sometimes brushed off, but can cause significant cognitive changes, and the help of a neuropsychologist is often essential here. Normal pressure hydrocephalus is a common diagnosis. Sleep disorders, masquerading of cognitive problems, though I haven't seen a sleep disorder as coming in as dementias. But demyelinating problems like leukodystrophies and multiple sclerosis can occur, dementia can occur in the late stages of the disease. So specific cognitive domains can clue you into different scenarios of dementia, etiologies of dementia. Amnestic syndromes are commonly seen in AD and Lewy body disease, hippocampal sclerosis, dementia, Korsakoff amnesia, and also thalamic strokes. People have small thalamic strokes which are not detected soon after the stroke or even post-stroke, but the size of the stroke usually is not a good clue about the significance of the cognitive deficits. And I have people come to me saying where the role of the stroke in their memory problems was not recognized. Post-encephalitis and trauma can cause hippocampal damage that may be missed or not diagnosed when it actually happened. And many years later, it presents as something like a dementia syndrome or amnestic dementia syndrome. Prominent visuospatial deficits can be seen in AD, including variants of AD like posterior cortical atrophy, Lewy body dementia, and cortical strokes, and in metabolic encephalopathy like hepatic encephalopathy, things like that. Prominent language difficulties are seen in AD again, and if you see consistently, AD can show up in different kinds. You can have a regional variants of AD that can sometimes confuse you. And so, as Dr. Cummings was mentioning, 40% of non-AD diagnosis ends up being AD. You can also have primary progressive aphasia syndromes and corticobasal degeneration. And all of these things can have concomitant language problems associated with that. Speed of processing deficits are commonly noted in vascular dementia and subcortical dementia, including Huntington's and Parkinson's plus syndromes, in AD again, medications, encephalopathy from medical illnesses, and demyelinating and post-traumatic injuries. So being aware of the different varieties of etiologies when you notice something is important to figure out the next step. Behavioral changes are clearly seen in behavioral variant FTD. You'll hear a lot more about later. In AD again, which can have a frontal variant of AD, which is easily mistaken for FTD. And you can have also pseudobulbar affects and behavioral changes from strokes and post-traumatic brain injury and some myopathies that I mentioned earlier. Motor signs are clearly noted in Parkinson's disease dementia, Lewy body disease, and Parkinson's plus syndromes like PSP. You can also see in CBD. So the idea is that different cognitive domains are clearly to be looked into, and you need to have 2 or more domains that are lost for a diagnosis of AD. So going back to what we really started out with, some of the factors that you need to be paying attention to. So you start out with a checklist of things. Look for abnormal labs or focal signs, Parkinsonian signs. Is there a gradual onset or a slow progression? Is there atypical features, which clues into different kinds of etiologies of dementia that we talked about. So in summary, there is a history of progressive cognitive decline. There's a change in ADL performance, 2 or more cognitive domains, and specific etiologies are clued in by specific cognitive domains that are being affected. And so clinical history is clearly important, and neuropsychology and lab and imaging tools kind of support that. But I want to end this talk with something that tied to the story of the maps I talked about. So this is a picture that I found when I was reading a travelogue of Marco Polo. It struck me because of one reason, and it's very prominent what the reason is. And what the second reason is that when Marco Polo visited Asia, he describes people with dogs, heads like dogs, eating flesh in islands close to India. And it is described in present-day Andamans. So what was striking was that by the time it actually got to Europe, the picture shows you actually men in dogs' faces, but well-dressed in European clothes, and there's a nice church in the background, and it gets transformed to a completely different worldview. So the point it raises for me is also related to the dementia story, in that when we look at different kinds of dementia etiologies and what they mean, it is our impression as it stands now. And it is an evolving field, and when you look 10 years from now and 20 years from now, it would be a dynamic change, and you are here at this point when you're looking at that aspect of dementia's progression. So specific etiologies I mentioned to you would also be changing, but being aware of that is the first clue and is a prominent job for the physician. Well, thank you very much.